Can I get to my presentation? Good afternoon, everybody. Thanks, Dr. Das, for that very nice introduction to the whole topic. I think in this very robust audience, I don't need to belabor the point about glargine. I just wanted to point out that because of these couple of amino acid changes, it improves the stability and it also makes it more soluble at a slightly more acidic pH, so that when you inject it, it forms it precipitates in the subcutaneous tissue, glargine, and then there is slow dissolution so that you get a protracted action and you get a no peak and a flat profile. Now, again, I don't want to belabor the point. I think we all know about glargine. We all use it quite extensively, and we know that it's extremely helpful for reducing blood sugars without causing hypoglycemia. And you have a once daily injection, and there are many, many studies which have shown this. No, but what was the reason for the controversy in the first place? Part of the reason is because of this, because of the similarity of the insulin receptor and the IGF-1 receptor and something called the hybrid receptor. All of these receptors are heterodimers. So there's two parts of the receptor, and the hybrid receptor takes part of the IGF-1, takes part of the insulin receptor. And you can see also that the predominant action of insulin is obviously on the insulin receptor and the hybrid receptor, but there is some spillover action on the IGF-1, and the similar picture with the IGF-1, which has a predominant action on the IGF-1 receptor, but there's some spillover action on the insulin receptor. Now, there are very many in vitro studies which have shown that glargine does bind to IGF-1 receptors much more strongly than does insulin. So in these studies, basically, they compare glargine with NPH insulin. And they show that on a comparative basis, for the same amount of, say, metabolic potency, for the same amount of binding to the insulin receptor, the glargine tends to bind to the IGF-1 receptor far more strongly than does insulin. This, one of the earliest studies that came out, was published in 2000, and it was done, we have to remember that it was done in this one particular osteosarcoma cell line, which predominantly only expresses IGF-1 receptor. So it is an extremely artificial situation. This is nothing like this usually physiologically in our body, and we have to keep that in mind. The same study also showed that the insulin receptor binding and the metabolic potencies were actually slightly higher for glargine as compared to NPH insulin and slightly less for detemer. That study that I'm alluding to, they used different cell lines. So this one was the human osteosarcoma cell line, was to look at mitogenic potency, whereas a couple of other cell lines were used to look at binding to the insulin receptor and the metabolic effects. Now, there has been a lot of in vitro studies, but I just want to point out one of the important facts that has emerged is that they think that the effect of insulin in vitro, the different insulin analogs in vitro assays, depends upon the ratio of the IGF-1 receptor to the insulin receptor ratio on the cell. So you can see that if the cell predominantly expresses IGF-1 receptor, there seems to be more mitogenicity. If there is sort of more balance between the IGF-1 receptor and the insulin receptor, there isn't that much of mitogenicity. So these are all artificially created cell lines in vitro, and we really should not be extrapolating from these in vitro studies to clinical trials. What about the clinical data? Obviously, in 2009, there was this slew of articles which were published in Diabetologia. We've heard about them. Most of them came from Europe, and they all showed that there seemed to be a slight increased risk for cancer. However, there was a lot of flaws with the epidemiology, with the way that the studies were done. For example, in the German health study, it appeared as though the glargine risk overall was actually lower than with other insulins. In the Swedish database, there was no conclusive data. That they said even initially. In the Scottish database, it did look like the group that used glargine was at increased risk for malignancies, particularly breast cancer. But if you went back and looked at the population that was given glargine, for some reason they were older, they were more obese, they were more hypertensive, and they were more likely to be on multiple agents, so long-standing diabetes, poorly controlled diabetes. So other risk factors for cancer were already present. And the UK GP database, which was also published around the same time, showed that glargine did not differ from other insulins. So there was a lot of controversy at that time, but ultimately most people felt that the epidemiological underpinning of all of these trials, or of the research was not particularly robust. I just want to point out 3 other slides, and I'll finish with that. The European Medicines Agency came out with this statement in May 2013, and they looked at 3 trials, and they showed that glargine does not increase the risk of cancer. 2 of these were cohort studies, and very large numbers. Look at the number of people they studied. About 2 lakhs in Northern Europe and another 1.5 lakhs in US. And the incidence of breast, colon, and prostate cancer with glargine as compared with other insulins was not increased. They also looked at a case control study. So they looked at about 750 women with breast cancer compared it to 750 women without breast cancer. And in the case control study also, they did not show that there was any increased risk of cancer with glargine. So their conclusion was that glargine does not increase cancer risk. And 2 other very recent studies, hot off the press, literally just published about a month or 2 ago. This one was published in Diabetes Care, and this was from somewhere in Europe, I cannot remember. They looked at 43,000 patients who had been initiated on insulin and compared them with about 9,000 patients who were initiated on insulin, on NPH insulin, in the same amount of time. And they found that, and they followed them up actually for about a year. But they had, because of this sheer numbers, they had very many thousands of years of follow-up, or years of insulin use for follow-up in the patients. And they showed that there was no particular increased risk of cancers with glargine. And this was a French study in which, again, huge numbers. They looked at 70,000, it was a little bit over 70,000 patients between the ages of 40 to 79 years who were started on insulin. They were followed up for about 2.5 years. And they showed that the absolute event rate for all cancers, so people who like to look at this number, you can see that the number of people who developed cancer in the glargine group, number of people who developed cancers in the non-glargine group. And overall, the risk of cancer in the glargine group was 0.97. The hazard ratio was 0.97, and the confidence interval was well across 1. And there was no increased risk, particularly of breast cancer, even after they sort of, adjusted for other risk factors. So in this particular study, in this French study, again, they came to the conclusion that in a very large cohort of patients, they did not seem to see an increase in cancer risk with glargine. So finally, I just want to say, I think I've made my point clear, and I really don't think there is any issue to be debated, but I'll be happy to talk about it. The basis of findings from epidemiological studies and the latest data, which from pharmacokinetic data, and there are also studies done in young children. That was the other concern. Can we use it in young children? And there are other studies which have shown that it is safe even in young children. So the chapter on whether insulin glargine per se is an independent risk factor for cancer should now be laid to rest and closed. Thank you.
Jayashree, thank you very much.